Welcome to the Breast Cancer Task Force educational series. This recording is focused on risk assessment, risk reduction, genetics, and screening. The mission of the Breast Cancer Task Force, a part of the Colorado Cancer Coalition, is to reduce the impact of breast cancer for Coloradans through risk reduction, early detection, access to personalized cancer care, and comprehensive survivorship support, regardless of social determinants of health, geography, or personal community identity. The task force is a statewide group of professionals, organizations, and community members working together to support breast cancer related efforts across Colorado. The task force provides a space to share resources, collaborate on projects, and highlight current work in the field. Dr. Marie Wood completed her medical training at the University of Colorado, interned in Minnesota, completed her residency at the University of Utah, and her fellowship at the University of Colorado. She practiced at the University of Vermont for 25 years and returned to the University of Colorado in 2022 as professor of medicine. She is an active clinician and researcher. Her clinical focus is caring for individuals with breast cancer or at risk for cancer. Her research program focuses on breast cancer biomarkers and mammographic breast density. A separate area of expertise or investigation is in cancer genetics, focusing on the use of cancer family history and identifying new models for cancer genetic counseling and testing. Dr. Wood has been involved in the Alliance for Clinical Trials cooperative group for over 20 years. She currently serves as co-chair for the Alliance Prevention Committee and is the deputy director for the Alliance Cancer Control Program. She has been involved with the NIH since 2008 and is a current member of the NIH NCI Prevention CIRB and Cancer Prevention Steering Committee.
Thank you and welcome to this webinar where we're going to focus on breast cancer, risk factors, screening, and prevention. As you learned, I'm Marie Wood. We're going to talk a little bit about risk factors for breast cancer, a little bit about how that might change screening options, and then talk about prevention options for breast cancer in the next 15 minutes. There are a variety of risk factors for breast cancer. Probably the largest is a genetic mutation, although as you'll see in a couple slides, that really applies to a small percentage of the population. Having a family history, regardless of whether you find a mutation or not, is also associated with risk for breast cancer. And as you can see, the more relatives you have, the greater the risk. Also, the closer the relationship, first degree, second degree, or third degree, the closer the relationship to you, the higher the risk. Having had chest wall radiation prior to age 30, for example, for Hodgkin's lymphoma, does significantly increase your risk for breast cancer. Having benign breast disease, and I'll define this a little bit more in a future slide, is associated with a fairly significant risk for breast cancer. We've heard a lot about breast density. It's really those individuals with the highest breast density that is associated with the highest risk. There are other moderate factors such as hormonal factors, including starting menses early or menopause late, or having your first birth after age 30. We also know that hormone replacement therapy is associated with a slight increased risk, and it's really having combined estrogen and progesterone and taking that for more than 4 years that really does increase the risk. Lifestyle factors such as obesity, alcohol, and not exercise are associated with a slight increased risk, and one of our future speakers is going to focus on this. I mentioned high-risk genes associated with breast cancer. There's really a lot of genes today that we now know are associated with breast cancer. We know that there are high-risk genes, some of which confer a very elevated risk for breast cancer. Others are high-risk genes, but not really associated with breast cancer. Other common genes, such as ATM and CHEK2, are associated with an increased risk for developing breast cancer. And there are low risk genes that are also associated with a slight increased risk. To look at this a little bit more differently, I told you that high risk genes are not common. So if this is the population frequency here, and this is the relative risk of breast cancer, those high risk genes are rarely found in the population, but they do have a high risk for developing breast cancer. There are other fairly rare but moderately penetrant genes that are associated with a lower risk, but still a significant risk. And then there are things that are associated with a high frequency in the population, such as obesity, alcohol use, and those are common factors, even though they're low-level risk factors. So I think this is a nice way to look at it. I told you that finding certain biopsy changes is associated with risk. This is a picture of atypical ductal hyperplasia. This is lobular hyperplasia, and this is lobular carcinoma in situ. Together, we call these benign breast diseases, and they are associated with at least a 20% risk of developing breast cancer down the road. We also have models that incorporate a variety of factors, and some people may have heard about these. A lot of times, people who are going to get mammograms get modeled risk performed. Sometimes if you're going to your PCP, you might also see this. The Gale risk incorporates age, when you started menstruating, the number of biopsies, the age at first live birth, and first degree relatives with cancer into a modeled risk. It has been modified to account for atypical hyperplasia and other factors. The Tyrer-Cuzick model was developed in 2004 and uses a more complete family history as well as a number of other factors. We can actually break people into three buckets of risk: average risk, which is about 12% lifetime risk; moderate risk, which I think of as somewhere around 15 to 20, and high risk, which is really greater than 20 to 25% lifetime risk. Thinking about factors, moderate factor, as we saw in that first slide, having some family history puts you at moderate risk. Having these biopsies showing atypia does put you at moderate risk. And some of those, as I explained in a previous slide, lower penetrant genes, which confer moderate risk, such as CHEK2 and ATM. The high-risk category includes people with a strong family history of breast cancer, especially diagnosed at early ages, having prior chest radiation therapy, and those individuals with highly penetrant genes, but again, these are not commonly found in the population. This does allow us to break people into three different categories with respect to their screening guidelines. Individuals at average risk should practice breast self-awareness. If they find a lump, bring it to somebody's attention. Begin their mammogram somewhere between age 40 and 45, but additional things such as MRI are not recommended. For individuals with moderate risk, we again recommend breast self-awareness. We suggest they begin clinical breast exams 6 to 12 months, beginning at, or have clinical breast exams every 6 to 12 months, starting 10 years before the age of a first degree relative at their diagnosis, or age 40, whichever is earlier. Mammograms should begin 10 years before the age of diagnosis of a first degree relative, or at age 40, whichever is early. And for this moderate risk group, MRI is generally not recommended. High risk groups, we again recommend practicing breast self-awareness, suggest clinical breast exams every 6 to 12 months, starting at age 30. Mammograms should begin at age 30, but start annually 8 to 10 years after you receive chest wall radiation for that group. MRI is recommended to start at age 25 to 30, depending upon the gene and the risk. And it starts before mammogram because it's less sensitive to breast density. Mammogram is influenced by breast density. And again, MRI should start 8 to 10 years after chest wall radiation therapy for that group. I do want to just touch on a couple of things about screening. We know that for women over 50, there is a 20 to 30% improvement in breast cancer specific survival for those who have screening. And the false negative rate, meaning it's a negative mammogram, but there's actually cancer there, is about 10 to 15%. There's been a lot of controversy around the age between 40 and 49, but it's important to realize that the data shows us that there is a 16% improvement in breast cancer specific survival for starting screening at that age. However, the false negative rate is larger, is higher, generally due to breast density. And there can be a lot of false positives, as high as over 50% in some studies. And this means a lot of biopsies and a lot of anxiety. So you have to balance both the false negative rate, the improved survival, and the false positive rate. For women under 40, the effectiveness of mammogram alone is really unknown. And there's a much higher false negative rate because things can hide, because that group has very dense breast tissue. I want to show you a little bit about how mammogram fails us for those high-risk groups. So here you see in 3 separate studies, the sensitivity of clinical breast exam, which is less than 30%, the sensitivity of breast ultrasound, which is again less than 50%. And so interesting to me, when you look at these studies, mammogram alone fails this population with a sensitivity of less than 50%. But when you look at screening breast MRI and what it can do, the sensitivity is so much higher, ranging between 70 and 95%. Studies have actually looked at both sensitivity and specificity and the ability to detect interval cancers for women who are undergoing high-risk breast cancer screening. And so here you see, as I showed before on the previous slide, the lowish sensitivity of mammogram, but a higher specificity. When you add MRI to screening breast mammogram, the sensitivity and specificity are both over 95%. When you look at what happens with respect to interval cancer development for very high-risk individuals, like those with a BRCA1 or BRCA2 mutation, 35 to 50% can develop an interval cancer. That drops to 10% when you add screening breast MRI to mammogram. I'm going to spend the next period of time talking about breast cancer prevention. And there's really 3 areas to focus on: lifestyle modification, chemo prevention, or taking a pill, and there can be hormonal and non-hormonal agents, and surgical prevention. With respect to lifestyle factors, and I know one of our speakers is going to focus on more, but we think about things like alcohol, exercise, healthy living, and breastfeeding. When we think about pills that you can take for breast cancer prevention, we think about agents such as tamoxifen or aromatase inhibitors. Generally, we offer those to individuals who are over age 35 with a 5-year breast cancer risk of a 60-year-old, or 1.6%. We also offer this to individuals with benign breast disease, such as lobular carcinoma in situ, or those other agents. It's important to realize, and I'll talk about this a little bit more, that agents like tamoxifen or aromatase inhibitor only prevent ER-positive disease. Risk-reducing salpingo oophorectomy, or removing the ovaries and tubes, has had some controversy over whether this really reduces breast cancer risk. We think about it as a risk reduction strategy for the highest risk group. And for BRCA1 carriers, we recommend it between age 35 and 40. And for BRCA2 carriers, it's generally recommended between age 40 and 45. There is a movement to think about just removing the tubes and saving the ovaries removal till closer to menopause. And this is really about ovarian cancer risk, not breast cancer prevention. But we do see breast cancer prevention effects when you remove the ovaries prior to menopause. Risk-reducing bilateral mastectomy is really for the highest risk groups, those individuals who have genetic alterations such as BRCA1 or BRCA2, or a very strong family history. We might also consider it for prevention of breast cancer for people who've had prior radiation therapy prior to age 30. I do want to talk just a little bit about hormonal prevention. We have several trials that have looked at selective estrogen response modifiers, medications like tamoxifen or raloxifene, and in aggregate, they reduce the risk of ever developing breast cancer by 30 to 50%. And when you compare tamoxifen to a placebo, you see that there is a significant reduction in breast cancer risk. Similarly, aromatase inhibitors, medications like exemestane or anastrozole, only appropriate for postmenopausal women, reduce the risk of breast cancer at least 50% and maybe higher. You need to subtract these numbers by 1 to get the actual benefit level. And again, compared to not taking a pill, they have a significant ability to reduce breast cancer over time. If we look at those studies, and this is tamoxifen, and these are aromatase inhibitors, you can see that for individuals in the dotted lines or the red lines who take the medication, there is a significant reduction in breast cancer risk that you can still see at 20 years, even though you're taking the medication for 5 years. And that's true for both tamoxifen and the newer aromatase inhibitors. However, to date, there's been no improvement shown in overall or breast cancer specific survival. And again, these agents only reduce ER positive breast cancer, so there's not a change in the risk of estrogen receptor negative breast cancer development. These medications have toxicity, so some investigators have started thinking about low-dose tamoxifen to see if we can increase the uptake of these medications. This is a very cool study enrolling women who were under 75 with atypia or LCIS or DCIS, stage 0 breast cancer. They were randomly assigned to 5 milligrams of tamoxifen or placebo. 5 milligrams is a quarter of the usual dose. They took this medication for 3 years, and we have follow-up at 7 and 10 years. When we look at the 10-year follow-up of individuals who took this low-dose tamoxifen or placebo, we see a significant reduction in the development of breast cancer. We even see a reduction in the prevention of breast cancer for women who had, say, DCIS in one breast. You see a significant reduction in developing breast cancer in the opposite breast. And what you're seeing here is treatment was for 3 years in both of these graphs, but you're seeing effects at 10 years or more. And so taking a short-term medication has long-term benefits. This study evaluated the toxicity of 5 years of tamoxifen, And you can see here in hot flash frequency and hot flash score that there was a little bit of increase in patients taking tamoxifen, but not what you would see if you gave women 20 milligrams of tamoxifen. Additionally, these are associated with a low toxicity of other complications. We worry about uterine cancer or blood clots when we give women full dose tamoxifen, and out of 249 women taking tamoxifen, they only had one patient with uterine cancer and one patient with a blood clot. There was also one patient with a blood clot on the other placebo group. They saw very much lower associated side effects than we would normally see with breast cancer. I'm sorry, with regular dose tamoxifen. So I think I've shown you a lot about risk factors for breast cancer and what we would offer screening based on risk and what options women have for prevention. And I thank you for your attention.